Good morning and thanks for this opportunity. So I'll be talking today on tackling trauma and poor capsular support in pediatric cataract. Children, as you all know, are very prone to trauma, and mostly this trauma is accidental. They get injured with the rubber bands, needles, pencils, sticks, playing with others, and even during festivals like Diwali when we do see a lot of traumatic cataract. So from Southeast Asia, the incidence of trauma in children and pediatric cataract is about 25 to 38%. And the most common etiology in our scenario is injury with a stick or thorn. And mostly these injuries are more common in boys as compared to girls. And oftentimes they are associated with other ocular comorbidities like injury to other parts of the eye like zonules or cornea and vitreous hemorrhage, retinal detachment, etc. So as you can see, children love to play with crackers, and this is a time when we do see a lot of injuries. So types, they can be an open globe injury like this when there is a corneal tear with a iris prolapse and traumatic cataract, or it can be a closed globe injury, blunt injuries causing traumatic cataract by the force. And in the third picture, you can see zonular dialysis with a cataract. So there are a lot of conditions where you need to make a lot of decisions here. One would be regarding the timing of surgery. So do you do this cataract at the same time as when the patient presents with the initial trauma, or do you wait? And cataract management along with the primary corneal tear repair, if there is a very big tear and if there is a rupture in the anterior capsule and prolapse of intraocular contents, then we need to take it up immediately. Otherwise, if the capsule is intact, we can take it up later also. And again, whether we need to implant the lens as a primary IOL implantation or as a secondary IOL implantation. Site of IOL, whether it is in the back or is in the sulcus. Other concurrent issues like whether there is any injury, other injuries, vitreous hemorrhage, retinal detachment, etc. And medico-legal issues, because some of these can be having a medico-legal issue also. So one of the most common difficulties that we encounter is how to take the clear topography in the setting of a traumatic cataract. So if the Mayas are very clear, then we can go with a manual keratometry or an automated keratometry. But if the Mayas are distorted, then what to do? So if we can rely on an OBSCAN topography here, and if the OBSCAN, as you know, takes the central 3 millimeter keratometry reading, and that can be used for the calculation purposes. If the Mayas are very distorted, then even after waiting for quite some time, the eyes heal with scarring, and hence if the Mayas are very distorted, we can go with the standard keratometry of the other eye, although this setting is very rare. And do not forget about amblyopia, because between the initial corneal tear repair and your management of the corneal tear and the cataract, it can be months before the optical visual axis is clear, and so many of these kids are prone to amblyopia, especially in the age group of 0 to 10. So we need to keep that in mind, otherwise a good surgery can be a waste if we don't think of amblyopia. So now I'm going to show you certain difficult scenarios of pediatric cataract. So this is a patient who had a very small self-seed corneal tear, and you can see the total rupture in the anterior capsule here, almost like the Argentinian flag sign. So the cortical matter is being aspirated through the ruptured anterior capsule, following which I am doing enlarging the rhexis. All the cortical matter has to be aspirated before you implant the IOL, because otherwise the incidence of proliferation, reproliferation and posterior capsule opacity is very high. So now the bag is inflated with a viscoelastic, and usually because it is a very big rhexis here, a 3-piece lens is preferred, because in case there is these cases are prone to inflammation, and if the IOL is going to come out of the bag, then the single piece will not be very stable. And all cases of pediatric cataract, we need to put a suture to the tunnel up to the age of 15 years at least. So you can see the well-centered IOL here. This is a case where the corneal tear repair has been done previously, and you can see the cataract which is a posterior subcapsular type of cataract here. There is a lot of iris tissue damage and some iris tissue loss also at 1 to 2 o'clock position. And the rhexis in a pediatric capsule is very elastic, and we need to be very careful while doing the rhexis, with usually done only with the help of forceps. It may not be able to complete with the needle alone. So since we have got a good rexus here, a single piece lens is being placed inside the bag, but there is a lot of opacity in the visual axis because of the dense PCO. So here the IOL is being lifted, and then the PPC has been done with a vitrector because of the dense fibrosis, and at the end of surgery you can see that the visual axis is quite clear. So this patient has a blunt injury. You can see that there is no corneal tear, but there is a very intumescent lens here, and also you can see that between the 7 to 9 o'clock position there is zonular dialysis and an iris tissue loss. So after making a small rexus, because of the intumescence, the cataract is being aspirated, and now you can see the area of zonular dialysis and iris tissue loss very clearly. So now a double rexus is being performed to enlarge the size of this rexus, and because there is area of zonular weakness, a CTR is being placed inside the bag, and that will give more of support when you are placing the lens. So this is non-paying patient, so we are placing a 3-piece lens, and it was an older child also. Following the placement of IOL in the bag, the iris tissue defect is repaired with the help of a Prolene suture, because since it is in the 7 to 9 o'clock position, there can be a lot of glare if we leave it just like that. So with the single pass 4th row pupilloplasty is done, and the pupil is reconstructed. This is a child who had a sclerocorneal tear repair done at 7 to 9 o'clock position, and that area where their initial injury has been there is a lot of synechia. So for better visualization, iris hooks are being used. I think you need to put the charger. So the iris hooks are being used for better visualization, and the cortical matter is being aspirated here, and the IOL is being placed inside the bag. So following this, by lifting the IOL, we are doing a small PPC here, because the age of the child being less, unless a PPC is done, the incidence of posterior capsule opacification is almost 100%, and then a generous anterior vitrectomy is being done, and the tunnel is being sutured. So this is a case who had a blunt injury with this was a cracker injury, and there was a lot of inflammation initially, and when the inflammation settled down, there is a very dense anterior capsular opacity. So this you cannot do a rexus in this case. You have to cut over this anterior capsular opacity with the help of 1R scissors, and then the loose cortical tissue is being aspirated here. So after aspirating the cortex, you can see that the posterior capsule has been polished, and now the visual axis is quite clear. As far as possible, this membrane is being removed so that it doesn't come in the visual axis. And now you can see that it's very clear, and 3-piece lens is being placed here, and then dial inside the bag. So this was an older child above the age of 10 years. So I have not done a posterior PPC in this case, and because also the anterior axis was not very good. So this patient has had a cataract aspiration along with the corneal tear done previously, and now is posted for secondary lens implantation. So the importance in secondary lens, you have to remember that always you should use a 3-piece IOL. You cannot implant a single piece IOL in the sulcus. Another thing is there can be a lot of synechia, and all the synechia has to be released before you place the IOL inside the bag, inside the sulcus, because otherwise within a few days there can be a pupil capture, and most of the IOL will be in the anterior chamber. So after reforming the sulcus, the IOL is being dialed inside carefully. There is a PPC already present, so just a vitrectomy, anterior vitrectomy is being done. And then in some cases, the visual axis can be it can be opaque. I think the laptop charger has to be connected. any questions you have in the meantime by he connects the laptop? Till now? Yeah, we do inject steroid. I didn't show it in the video, but we do inject steroid, 0.5 cc. And also we can do under steroid cover if we feel there is going to be a lot of inflammation. We can give preoperatively also, we can start on injection IV Decadran. Usually in the uveitic cases we do under a strong steroid cover. Yeah, Decadran. We use Decadran in our setting. Yeah, but okay. Thank you.
We also use intracameral moxifloxacin for all the applications. We give subconjunctival Decadran.
Subconjunctival, yes. So traumatic cataract, there can be a lot of surprises on table. So that's why you need to always be open to the, sometimes we may need to put an iris fixation, or we may think that there is enough support, but then we may need to do a scleral fixated or an iris fixated lens. So proper planning is essential. Sometimes the pupil may not dilate as well. So on table we may be having some difficulty in stabilizing the lens. And when we want to do keratometry, sometimes in a dense corneal scar, then we may not get a good K reading as such. But when we take the OBSCAN value, we can get the central 3 mm reading if the damage is peripheral. And then we can compare between our manual K reading and the OBSCAN K reading, and we can take a mean of the two and then decide on the lens power. The initial corneal tear repair we do like as soon as the patient comes in. Usually even if it is a Sunday, we prefer to take up the surgery on the same day and do it as far as possible. But regarding the IOL placement, it always depends. We should think, and if everything is okay, then we can place it at the same time. Mostly when the corneal tear is very small, then we can place an IOL at the same time. But if it is a larger corneal tear, then we can place it in a secondary setting, which is more safer with regard to the lens power calculation, and also the inflammation is very less. So if we place the lens at the same time as we are doing the surgery, then most often there can be a dense membrane also on top of the IOL, and we may need to take up the case again for membranectomy. So secondary lens implantation is better if there is a very severe injury to the eye. Yeah, we do. Mostly in all cases we do use Trypan blue. Not at all, not at all. I don't think Trypan blue increases the inflammation. Yeah, vitrectomy can be used only in very small babies. As like in any baby above the age of 6 months, using a vitrectomy to do the anterior lens, anterior excess, I wouldn't recommend, because yeah, then you have to operate only within the area of fibrosis. That area of fibrosis was not big enough that we can do the vitreous excess in that case. If the fibrosis is very large over the entire anterior lens capsule, maybe yes.
Because it gives a very round, you can take a very round, clean rhexis with a vitreous, though not as good as a manual rhexis. True. In particularly traumatic cases with fibrotic capsules.
Yeah, but that case was it was not central, it was a little eccentric. So if you do only in that area, then the visual axis, there will be that area of fibrosis again coming and hampering visualization. So when we are
doing... No, I'm telling you about the anterior capsule.
Yes, anterior capsule,
yes, anterior capsulotomy.
Yes. Because that was not exactly in the center, that was a little off center. I'm sorry, sir, I'm not able to hear.
Regarding the scleral fixated lenses, what is your lowest cutoff
Regarding
limit? SFILs.
SFIOLs, I would say around 8 years of age will be the lower limit. Because below that, the scleral rigidity is not that good. So there is a lot of chance of getting postoperative hypotony. So I would prefer an age of 8 years for scleral fixated lenses. Yeah, I do.
इसको दवाइयो एडीएमएट दवा एडीएमएट दवा हो गया मैम आप क्या नहीं ये एक मिनट
एक मिनट
एक मिनट आप कर लीजिए कोई बात नहीं आ गया मैम नेक्स्ट
Excuse me. I just want to advance that. वीडियो में वो एडवांस कर दूँगा
ऑडियो
वो नहीं वो एडवांस कर
ये लास्ट है
हाँ लास्ट है उसमें तो मैंने आधा वीडियो ख़त्म हो गया एक्चुअली ओके अब से आप देखो ओके फाइन
एक मिनट क्या करना है
वो आधा वीडियो एडवांस करना है यही से प्ले करो
How many here in the audience do pediatric cataracts? What is the youngest age you prefer to put an IOL implantation? 2 years, sir. If it's unilateral cataract? More than 1 year. Anybody has a different opinion? IOL implantation, sir. And your follow-up of? You took the haptic. What type of lens was it? Okay. What type of lens did you put, sir? Okay.
Ma'am.
And what was the corneal diameter? Okay. And do you have a follow-up of, how long do you have follow-up, sir? And it's
I did posterior capsular rexis plus vitrectomy, and both eyes were good. It was associated with alternative convergent skin.
I see.
After 1 year, I had corrected skin also.
Oh, okay. So you've done squint surgery as well.
Yeah, we can go, yeah.
Okay.
So this is the next case where temporal clear corneal approach is being used for secondary lens, because superiorly, as you can see, the corneal tear repair has been done and there is a lot of hazy media. So here the posterior capsule is fully intact, though there is a lot of synic A which I am releasing now, so to have the space to put the IOL inside. So after releasing the synic A, you can see the clear corneal incision is being made. And the white color opacity that you are seeing is the anterior capsule actually, and the posterior capsule is fully intact. But in this case, I was not able to separate these two layers, so I am going to place the 3-piece lens only in the sulcus. But in certain cases, if you are able to separate the two layers, then you can attempt implantation inside the bag also. And here, after filling the bag with the viscoelastic, 3-piece lens is being injected into the sulcus. And then following this, we need to do the posterior capsulotomy here, because the PC is fully intact and it already shows some minimal posterior capsule opacification. And if we leave it as such, then there will be a dense opacification within a month or so. So the size of the posterior axis should be around 3 to 4 millimeters in size at least. So we are making the initial nick and then enlarging it with the help of the forceps. So along with that, in our institute, we do the PPC and the anterior vitrectomy up to 10 years of age at least, because that ensures a good visual access, and yaw capsulotomy in very young children is not very easy to perform. So you can see the visual access is clear here. In case the corneal opacity is coming right over the visual area, you can do a small bit of optical iridectomy or a pupilloplasty also, so that the visual access is clear. So here again you can see the secondary lens being implanted. Most of the capsule is, posterior capsule is intact except at the site of the initial injury, where you can see that there is a dehiscence, and also there is a lot of opacification in the visual axis itself. So I am trying to release with the spatula, but since being unsuccessful, cutting it with the help of the Vanna scissor, because we need to form the sulcus in that area also, otherwise the pupil is going to get captured there. So after cutting the iris tissue with the Vannas, there is space for injecting the IOL there now, and hence then after all the synic A has been released, the IOL is being injected inside the you can inject it entirely into the anterior chamber also and then dilate into the sulcus, which is more easier. And then following this, that you can see this area of fibrosis which is coming right in the visual axis, and that area has to be cleared now. So after lifting the IOL, then you can see the membrane is very thick. So sometimes these membranes will not be able to cut with the vitrectomy, and then you have to go with the micro forceps or the Vanna's scissors, and then you have to enlarge that area of fibrosis. So now after cutting that, the visual axis is quite clear now. So the child's visual potential will be good. So here again you can see that there is an area of posterior rent, and I am not able to see how far the posterior capsule is, support is available in this case. So using iris hooks, then we found that the nasally for around 5 clock hours, the posterior capsular support is not there. So the capsule is present only inferiorly, temporally and superiorly, but nasally absent. So injecting the IOL with oriented vertically, so that the haptics are oriented vertically, and it will be stable. But even after dialing it vertically, sometimes it can rotate and then it can become unstable. So in such situations, it is better to put an iris fixation. So I'm doing an iris fixation here and using a proline suture, fixating the superior haptic to the iris, so that the lens will remain in that position and post-operatively will not rotate. So with the proline suture, that superior haptic is fixated to the iris, and now you can see that in the visual axis the IOL is centered. Again, this is a sclerocorneal tear repair with a very small pupil, and the iris hooks are being used mainly to do the posterior membrane has to be removed fully. And after injecting the IOL, we can also do the PPC and then inject the IOL, but in our institute we are used to doing it this way. And this membrane is very thick, so it has to be cut with the scissors and then enlarged with the help of the vitrectomy cutter, and at the end of surgery the visual axis is very clear. So iris hooks can be very useful, or any form of pupil dilating device is useful. In this case, last case, the PC support is totally not there, so scleral fixated lens is going to be done. So we are doing this scleral fixation with the help of two partial thickness scleral flaps which are created nasally and temporally, and then the IOL is being taken out with a needle guided haptic insertion technique, where you can see that the inferior haptic is introduced into the hub of the needle, and then similarly the superior haptic is introduced into the hub of the needle and then externalized, and with the help of silicone stopper you can fixate it for the time being, and then you can bury it inside the partial thickness scleral flaps. So this way the IOL is very stable, so you need not create the big scleral flaps as such. The partial thickness scleral tunnel is quite sufficient to tuck in the haptics, and the IOL is centered here. And following this, you can suture these two areas so that the post-op hypotony is not seen. Thank you.